And without further ado, I'm going to introduce Dr. Rachel Rube. She's with Waco Family Medicine, and I'm going to read her bio straight off the script. Dr. Rube was born and raised in Northern California, but found herself transplanted to Texas at age 17 and has been here ever since. We're glad of that. She attended Baylor University for undergraduate, BS in biology, minors in Spanish and chemistry, and later attended University of North Texas Health Science Center, Texas College of Osteopathic Medicine, TCOM for short, much easier to say. She vacillated in her career paths from hopes to be a Spanish lit professor to a physician, and found a beautiful combination of her two loves, teaching and healthcare and academic medicine. And you know, you could come down here to South Texas and we could probably put those skills to work for you. A lot of Spanish speaking down here. She completed
you probably
residency.
See me teach before you offer.
Yeah. She completed residency at Waco Family Medicine Residency Program and was lucky enough to come on board as a faculty physician after graduation. She is married and has a fun and tenacious daughter named Emery and two dogs. She likes to say she is passionate about the P's of medicine, the pediatrics, pregnant patients, public health, and psych. So family medicine allows her to practice broad scope while tackling interpersonal and systemic issues that contribute to healthcare inequities in the U.S. I got through that fairly okay. Dr. Rube, I'm going to turn it over to you. You have your slides ready.
Yes, I do.
Screen share from your
great.
screen.
Let me go ahead and pull it up.
And we're glad to have you.
Thank you so much. And thank you for having me. I appreciate it. So let me go ahead. Post disabled participant.
And her subject today is fetal alcohol spectrum disorder.
So real quick, I click on screen sharing and it says the host has disabled participant screen sharing.
I didn't mean to do that.
So I'm not sure if that is going to be an issue.
Multiple participants can now share.
Thank you so much. I appreciate that. Okay, so let me go ahead and pull it up. Okay, so you guys are in my side. Okay, can you guys see it okay? Give me a thumbs up or a, okay, great. And I love active participation. I'm not a human of brevity, so you have the right to cut me off or raise your hand or holler at me, but I do appreciate, you know, if I ask a question in the middle of it, feel free to put it in the chat, and Charlie, you can go ahead and verbalize it, or you guys can just spout it out or give a little wave. Okay, so the main thing I start off with, I make no money doing this, touting my information. I just like to teach and work with others on making a difference. So I will not make any money, don't you worry. No disclosures. And then, so we'll just kind of jump right in. So what is fetal alcohol spectrum disorders? So who do the little emoji for raising your hand? Who has heard of fetal alcohol syndrome? Yeah, right. So that's the most common one. The way you kind of look at it is there's a spectrum of disorders. It's actually a range. So manifestations can be anywhere from physical only to developmental, behavioral, to a combination. So we're going to kind of break that down so you guys can understand that it's actually a lot more pervasive than just what we niche it to fetal alcohol syndrome itself, which is the most severe version. It's associated with prenatal alcohol exposure, and it's a lifelong condition. So if you are diagnosed with one of these conditions, then you have it forever and there's no cure. It is something that you have, like autism or Down syndrome. Okay. So this is an umbrella term, right? So fetal alcohol spectrum disorders. So what does that encompass? So there are 5 that are kind of accepted widely. They vary internationally by what the names are. So I kind of standardized it under the most convenient nomenclature for the US. Okay, so we all are familiar with FAS down at the end, right? Is my video coming through okay, or is it having a lag? Okay, great. So FAS, or fetal alcohol syndrome, is the most severe form. It's got both physical characteristics and developmental neurobehavioral stuff. Down at the other end of this umbrella, you have things that can have partial FAS, which is only some of the physical features and lacking specific imaging studies on the brain or evidence of brain development changes. And the others on the other end can be anything from the ARBD is a alcohol-related birth defect. So they may not have the syndromic face and neurodevelopment, but they can actually have defects of the development of their heart, kidneys, and things, and we'll go over that in detail. And then the alcohol-related neurobehavioral disorders, there's nothing physically developed wrong on them. You can't see it on their face. You wouldn't see it on pictures of their brain, but you see it in the way they interact, their social interactions, the way they interpret situations, the way they have judgment on decision-making. And then that can also have, there's another one that's variable in its acknowledgement is the neurobehavioral disorders that are related to prenatal alcohol exposure. And there's tiny nuances, but that is kind of a spectrum of saying there's behavioral without physical changes, and then there's physical changes without the behavioral, or a combination of the two. And that's the most common fetal alcohol syndrome, if you have more or less all of those things together. This is ticky-tacky, detail-oriented. If you want, I gave Charlie the slides, but this is the basic criteria for diagnosis. So that's kind of that same breakdown with the nomenclature, okay? So what are the stats? The hardest part about fetal alcohol syndrome disorders or fetal alcohol disorders is the prevalence is really unknown. Why is that? That's because we don't always diagnose it. It's hard to catch because some people just chalk ADHD and poor judgment or in certain social situations or inability to read a room as just that person. But how do we tie it back to nascency? How do we tie it back to in utero with alcohol exposure, which could have contributed to that? So it's really hard to gauge. Overall, prevalence is highest in United States and Western Europe. And there is an estimate in the CDC data for the United States that 1 to 5% of all children in the US have a fetal alcohol spectrum disorder. That's a lot. Like that's a lot of kids that have had some antenatal exposure to precipitate something different in their biology or in their physical appearance or in their behavior. 800 to 8,000, that's why it's such a wide range, right? We can't really definitively say chicken or egg. There's a lot of common combined elements, but a broad array of kids are diagnosed with fetal alcohol syndrome, the most severe form. And as many as 40,000 babies are born each year with FASD. Now, numbers. I can throw out numbers all day to give you some perspective on it. Fetal alcohol syndrome is as prevalent as Down syndrome, okay? But how readily do you recognize Down syndrome versus fetal alcohol syndrome, right? Like you can, in a movie or a show or a picture, you can say that kid has Down syndrome, but it's harder to discern that kid has fetal alcohol syndrome. So it's not as familiar to people, but it's equally prevalent in the US. And then when you're looking at it in context, the whole spectrum, the spectrum, any of those disorders on the spectrum is more than autism spectrum disorders in number of kids affected by it. But we hear more about autism and behavioral management, but where is all the intervention for the fetal alcohol spectrum disorder kids, right? So there's this dissonance. It's really, really present, but it's not being managed in the same way as these other more evident things that may be even less prevalent. So why is there no diagnosis? It's often called an invisible disability. If you don't have the full facies of fetal alcohol syndrome or partial, it could all be inside or behavioral, and we miss it. Doctors miss it because we're not looking for it. We're looking for the other things associated, but we're not necessarily keying in on, oh, Mom, was there any chance that you had drank during pregnancy? It's also a really hard conversation because people feel accused, right? So you guys all work with individuals that struggle with the disease of addiction and substance use disorder, right? How many people get defensive the first time you try to talk about it? Ooh, lots. So it's breaking down that stigma to be able to actually get into that conversation safely with a parent, especially because who would ever want to harm their children? Nobody, right? So they feel like you're saying you hurt your baby. You didn't care about them. You didn't love them. You know, so it's a really hard diagnosis until you build that rapport to break down those stigmas to be able to have an honest and open conversation if alcohol was even used in pregnancy. So how do we get there? Well, this will be a really quick rundown of the pathophys. Ready? So you drink alcohol. What does it do? Absorbs, gets in your bloodstream, goes to all your organs. And when you're pregnant, it goes into your placenta. In mom, what does it do? Goes through the liver, you get it out, peeing and pooping, leave it, get it out of your body. And that's that. You're drunk for a while, or you have a buzz, or whatever happens, it's in your system. And then it goes away. What happens when it hits that placenta though? So when it goes to the placenta, it enters the baby's bloodstream, just like it does mom when she drinks it. But then what? We don't have as developed livers in the uterus than we do as an adult. So the way the blood flow works in newborns inside the gestational sac is it goes past the liver. Okay, so strike one, right? It's going past the thing that breaks it down. So metabolism is less. Then what? Then we have it really slowly going out because it is floating around and not getting broken down. So it's just circling back and back and back. So what do? We pee and poop it out. We get it out of our bodies. What does the baby do? The baby pees it out. But where does that water go? It's a closed system in there. So it stays in the fluid. And what do babies do? This sounds gross to those that may not be as medically savvy or medically inclined, but the babies drink or swallow that amniotic fluid. So they basically have a second pass here, and that keeps going, okay? So their exposure is significantly higher than what ours is. They actually only eliminate or excrete that alcohol that you consume at a rate of 3 to 4% of the rate that the mom does, right? Think about that, 3 to 4%. So why do I bring this up? I bring this up to say alcohol is a teratogen. That's a technical term that says it interferes with the growth of a developing fetus, okay? So when you have a teratogen in the system going through with first pass and second pass, and however many passes it takes that baby to slowly metabolize it, pee it out, spit, swallow it back up, get it out, it causes a dangerous effect to that baby, dependent upon how much exposure you get. There is no safe amount of alcohol in pregnancy because even one drink takes that long to process. It depends on what's developing in that time that it's going to impact. Now, there is a dose, there's no specific dose response to say they will get on this spectrum of disorders with one drink, but we can't guarantee that they won't. And the more frequent use and the more volume used has a higher risk associated with developing one of these disorders within the spectrum. So the take home is that it sticks around for a long time. The exposure isn't just that one drink and done. It's 1 drink, 2 drinks, 3 drinks, 4 drinks until that baby gets it out. And that can cause significant harm depending on where it is in the system or where it is in gestation. So here's the breakdown of the 3 trimesters. So first trimester, second trimester, and third trimester by weeks. So how does alcohol affect the baby in each trimester? It's got the biggest impacts in the first and third trimesters. The second trimester is the highest risk for loss of pregnancy, stillbirth, and miscarriage with alcohol use. But the syndromes and the spectrum of disorders comes when a baby is exposed usually in first and third trimesters, second trimester as well if they do not lose the pregnancy. So in the first trimester, you see most of the organs being developed. That's the period of what's called organogenesis, right? So if you have everything developing, what does alcohol do? It blocks normal nerves growing and going where they need to. It increases a toxin called free radicals in the body and the fetus. So it increases damage to cells. And it keeps the cells from moving where they're supposed to. Certain chemicals are supposed to be sent out to get things where they need to get to. And they don't get where they got to get to. That causes significant developmental disorders, which can be anything from a birth defect inside, facial development changes outside, or the brain development, which generates these neurobehavioral disorders. So first trimester, you see damage to kidneys, the brain, the bones, the eyes, the ears, the lips. We'll kind of go over that. And there's also that damage to the DNA. So it's down to a DNA level with those free radicals, okay? Third trimester exposure. Why is that a big deal? All organs are made, right? So they should be fine. No, unfortunately, that's when most of your growing and your nerve connections are being formed because the complex work is being done, right? You first got to start with something, sculpt it, and then what do? You chip it away and make it fine-tuned and beautiful and as perfect as you can when you're making a piece of art, right? That's what the uterus and the mama's body does. So in that last trimester, what do you see? You see more of those on the disorder spectrum where you see changes in their, sorry about that, changes in their development of their brain, the connections that they make. So let's see what that means, okay? So here are some examples of what it looks like in the syndrome, fetal alcohol syndrome or spectrum disorder, and a few of the physical characteristics. So what do you guys notice? And it's okay if you chime in. If you don't want to, I'll just talk. I'm fine with that too. Okay, I'll just talk.
Differences in eyes.
Yes, their eyes. So one thing that you notice, it's called short palpebral fissures. The opening of the eye is smaller than normal for that ethnicity. And the reason I'd use this photo is because it shows it in different ethnicities, because these kids look similar but different, same but different, right? Like it's a little different in each ethnicity, right? In Native American, which is in the middle, and Asian, you see epicanthal folds that are increased. That's that piece of skin that kind of point is right here, kind of bridges over, and it makes the eye kind of look a little bit narrower this way. So that's the epicanthal folds. They can have increased version of that. And then what do you notice about their mouths?
That's what Laura Jordan put in the chat.
Oh, perfect, perfect. Yes, so you notice that their lip is super thin on the top. You get a really thin upper lip and what's called a smooth philtrum. So everybody feel their face. Okay, you have a little divot right under your nose. That's your philtrum. Who knows why they named it? Maybe a guy named Phil dubbed it, but who knows? So the philtrum, I'm sure there's a technical term, I just don't know. So the philtrum is that little divot right here between the top lip and the nose, and it's flattened on these babies. So they have this flattened space and this thin upper lip. That is the most characteristic facial feature that you'll see with fetal alcohol syndrome, okay? And then we notice the eyes. And then on the third picture with the little African-American baby, you actually see what's called railroad ears. So do you see that the inner part right here sticks out further in a pattern with the upper portion of the ear, the pinna? So you see that's called railroad ears. So it looks like railroad tracks ridged up. You know, a lot of people's is kind of receded inside, but when it sticks up pretty prominently, that's called railroad ears. And that's another thing that you can see in fetal alcohol spectrum disorders. Okay. So other things that can develop, click. Okay, there we go. This is the big one. Okay. So we can have kidney defects, heart defects. One of the most common is that horseshoe kidney where they're connected, they didn't fully separate, damage to the nerves, hearing problems. But I really want to hone in on the brain development, okay? So what do you notice about these MRIs? The one on the left is a normal brain, and the one on the right is a fetal alcohol syndrome patient. What do you notice? Overall, microcephalic, smaller head, smaller brain, right? Because that third trimester, right? What is it doing? It's trying to grow. So alcohol exposure can limit growth. You have less volume, right? Less little curvies, less gyri, which is those neural connections, right? And then look at the cerebellum. It's the little brain in the back where it's got a pocket on the backside and it sits there like a lump of cauliflower or a piece of broccoli. What's the difference there? You got more space. Why you got more space? It's not as developed. So we'll go and we'll kind of tie these things together as we go forward. The other thing is that corpus callosum, the bright white spot in like the middle of the picture is called the corpus callosum. It's the connector between the two sides of the brain. So we are better at integrative thinking when we work with both sides of the brain. But theirs is in fetal alcohol syndrome, it's thinner. It didn't develop as well. Those connections are not as strong. So they can't dual process as readily as a patient that doesn't have these deficits. So these are visible changes that can happen. And that's a big deal because it's going to impact them in lots of avenues of their lives. So how does that impact the mind, the function of them, the behavioral aspect? Well, kids with fetal alcohol spectrum disorders can have impaired memory, learning disabilities, difficulty with space and time perception, and they can have a lower IQ. It's not definitive that they have all of these things, but it's possible. They can also have problems with their balance. The cerebellum, it controls how you move, how you coordinate. And when you have less of that tissue, you have less of those nerve connections, you have poor balance. And then they can also have sensory processing issues, kind of like kids with autism, with food and texture aversion. So they could have difficulty with speech or eating. And then the big ones that people see the most are emotional control issues, impaired social skills, trouble with judgment. They can't read a situation very well. They might be interpret something incorrectly as affectionate or aggressive, and ADHD. Okay, so these are things we keep on our radar. And if we start to see a lot of this, we say to ourselves, is there something going on here related to that? So what does this mean for their lives? Well, in the beginning, you see the physical effects, the lower birth weight, smaller development of the organs, the things that you notice about the brain development. But then what happens when they get older, childhood age, adulthood? You start to see those behavioral things. And you start to notice that they might have struggle with their peers. They might be volatile in their emotions. They might dysregulate. They might have issues with impulse control. They might have issues in school with learning disabilities. But how does that translate into adulthood? I want to hone in on three key points. Kids with fetal alcohol spectrum disorders have more problems at school. Okay. They have difficulty with building relationships. And they struggle with substance use disorder of their own. They have higher rates of issues with incarceration and issues with legal issues. So in school, 14% of children and 53% of adolescents and adults that have a fetal alcohol spectrum disorder have a disrupted school experience, whether it is time off, whether they are suspended, whether they have to transfer schools. Something happens to a very large number. Up to half of them in adolescence have some sort of disruption. Legally, similar scary numbers. About half of the kids that become adults with fetal alcohol spectrum disorders end up having legal trouble in their lifetimes. That's a big deal. So how do we help these people that are struggling with this? It's multimodal, obviously. I mean, it's so diverse. It's got such a broad array. We're not honed in on like fixing the facial defects, but the birth defects we can do surgical. But what do we do for that neurobehavioral component? What do we do for that social interaction portion? We do focused education. We inform them, this is what you have. This is how it happens. You destigmatize it. You tell them this is not your mom's fault or your fault. We're not blaming anyone. We're addressing what's at hand. And it doesn't make you stupid or lesser. It is something that, just like diabetes, you have this, and we're going to work together to get through it and help you succeed and thrive. There's tons of therapies, whether it's an aversion with eating or talking, or it's a balance issue. You have therapies like PT, OT, speech therapy. And then there's also a big push for animal integrated therapies, because FASD patients actually do really well with emotional support animals and things that involve animals. They actually really relate to them because the way they communicate, they can read their body language much more readily than people, because people have a lot of nuance to what they say and do. And dogs and animals tend to be more direct. So it helps them figure things out relationally. Counseling is always going to be a big helper, kind of in the same team as therapies. And there are medications, like not specific to FASD, but the associated conditions like issues with impulse control, ADHD, learning disability specific things, tools that you can use. But what do you guys think is the most important target for management for FASD, for fetal alcohol spectrum disorders? Prevention, right? Prevention. I am a primary care doctor. My life is prevention. So I get excited about this because it's hard to look somebody in the face with FASD and say, there's no cure. But what can we do? I can help you succeed and thrive, and you can help others understand it and avoid this perpetuating. Not that you're bad or have a problem, but it's something that you have to struggle with, and let's see if we can help others with that struggle. So alcohol use disorder in pregnancy, 1 in 10 women reports that they've drank some form of alcohol during pregnancy. With 30% of those women having something, and up to 30% in some studies, and near 8% report binge drinking, and that's a large volume in one sitting, right? And then you have, most commonly, it's in the first trimester, often before people know they're pregnant. But here's some stats that I found interesting in the CDC's database. The highest risk of use is in high education, older moms that are multiparous or have multiple kids, white, and in the United States. So people of affluence say, it's okay, or I've had so many kids, they're all fine, they're great. I've got this. So there's this assumption, right, that it's people, or there's often an assumption that it's people of color, people that are addicted, people that, it's all these people that you would look at them and say, oh, they probably did drink in pregnancy. No, it's the really affluent, well-educated lawyer that has a glass of wine every night while she's pregnant because it's fine, because I've had 3 kids and it's no big deal. So these are the people that, this is what's saying screening is going to be really important universally, because we can't make stigmas and we can't make assumptions and stereotype that one person is going to be more likely than another, because the higher stats of use are in this population. So how does this relate to polysubstance use? More than half of pregnant women who used opioids for non-medical reasons reported drinking, and more than 5 drinks in a day during a 1-month period. So why is that important? Is because there's higher risk in this. So you have this subset that's more likely to be alcohol use specific disorder in pregnancy. But on the flip side of that, polysubstance use, you want to be on the lookout for patients, especially like this with the overlap with opioid use, 5 or more drinks over a month. And they don't explicitly say which trimester it was in. It was a study in 2017 that was done in the US. But overall, that's 50% of women that had struggled with opioid use disorder had this meant alcohol. So the overlap is there, right? So what does that mean? Why isn't there a lot of data showing a link between FASD and neonatal abstinence or opioid withdrawal syndrome? The reason being there is a dissonance between the two. When do we diagnose NOWS or NAS? We diagnose it when a little baby comes out. We see withdrawal. We witness the effects. We can test mom in the moment for recent or remote use with the UDS or the MEC drug screen from the baby. So we have 8 ways to detect the opiate in mom and baby system, and we see a physical withdrawal, right? You don't always see physical heralds, but you see these 2 things. Alcohol use, it's in and out in mom and it's gone. It doesn't, we don't check it on tests in mom and baby. We don't check it on tests in mom and at delivery. And we don't often diagnose it until they're older. So we don't have this overlapping data, even though it's probably there, right? Because we're looking for one in the neonatal period, and we're looking for one, or not even looking at all, for the other, right? Their big overlap is in neurobehavioral deficits. So you can have a synergistic effect if using one can have an amplification of the other on their overall functionality. And you can have that overlapping data with the issues with legality and school. Okay, so what do we need to do? Well, by golly, it's 100% preventable. We need to talk to people. We need to destigmatize the conversation and have it with every single pregnant woman, because everyone's at risk to be using it or have used it in their lifetime, in their pregnancy especially. And so we can help them with that risk. I actually had one patient who came and was the sweetest girl who never really, nothing was ever wrong, never complained about anything, was excited she was pregnant. It was her first pregnancy. And I had noted, she had said something about her birthday party. And I said, well, how was your birthday? And she told me about it. And she said something about getting blackout drunk. And I was like, oh, how recently was that? And she was like, oh, last week. And I was like, okay. I was like, so how you're about 10, 11 weeks now. She was like, yeah. And I was like, okay. So what do you know about alcohol use in pregnancy? And she didn't know. She didn't know that it could be a problem. She's like, oh, I only do it every once. And so we had we quantified, we used these screening tools, the TASTE, the tweak, the audit. These are 3 standardized, really good ones that are pretty brief and really fairly sensitive and specific to diagnose or have high suspicion for alcohol use disorder in pregnancy. So you asked these, and she came out with a positive screen, and she openly went into a conversation about her depression that she hadn't talked about and feeling really anxious, her issues with the significant other in the situation, and it opened doors to say this is a safe space. This is something that happens, to normalize it in a sense that many other women struggle with this. Over half the US has 1 in 10 women will say they've used at all, like some, and then over 50% of women have exposed that they've binge drank in their pregnancy. So it really set a different course and a different trajectory for her pregnancy. And now she has a healthy, beautiful baby boy who has none of the physical outward characteristics, no birth defects, but we're going to see how developmentally he develops over time. But she was really grateful that she was able to talk in a safe space and be screened out positive to kind of follow from there. So when you have a positive screen, you go over the risks, you go over their options. We looped in our integrated health managers, which are LCSWs in our system, and they also have behavioral health training. And she followed with her every OB visit, and they've developed a good relationship. She started counseling. We talked about medication for mood, and it really did make a difference in her overall life and course for that gestation, and looping in others, teammates that would really help her in success. Be clear in your documentation. Don't fudge around it, right? If you're a medical professional, say it outright. Yes, their records are open to people, and we should be speaking to them as plainly as we are writing it in our notes. Patient struggles with alcohol use disorder, discussing risks with patient over time, building rapport, hopeful to help with implementation of resources over the course of her pregnancy. So offered support, talked with counselors, be honest, be direct, and be clear, because if we don't pick up the ball and talk to each other about it, then we're not going to be able to help them in any way, right? Beating around the bush is just going to leave them hanging. Resources are going to be key, and resources are going to be relative to your location. Off to the side, sorry, I kind of skipped that, is a few for us locally in Waco, because initially I developed this talk for Waco, but there are international resources, and I have it listed at the end of my PowerPoint. There's nofas.org is a really good website that's actually established in the UK that has really great resources for patients and families with an FASD diagnosed person. And so that is a really good option. And the CDC actually has really good information about FASD, how to plug in, and statistics that help some people kind of wrap their head around when they want to intellectualize it before they kind of can digest it emotionally. So the take home on this whole talk is that it's a diverse spectrum, and it's really widespread, but it's underdiagnosed. And earlier detection is what's going to yield better outcomes for the patient that's diagnosed with it. But really, above all, is that prevention is key. And if we don't make it a safe thing to talk about especially with your primary care doctor or with your friends and family, then it's something that we will never get ahead of. So we need to destigmatize it. We need to be open. We need to listen, meet people where they're at, and then help them get plugged in where they need help. So I am ready for questions. Do you guys have any? Do you want to? Yeah, maybe. These are the resources, by the way, if you guys want. And I'll leave it up for just a second. So if anybody wants to write, or Charlie, you have the PowerPoint.
Yes,
so if
I am recording.
Awesome. So ultimately, I'll make my face big, and so I can see all of you in a more conversational pattern, but this is it, and I'll stop sharing.
Dr. Rube, Laura Jordan is the senior Medicaid analyst with the state, and she's interested in how Medicaid can improve policy development or coverage, and she's been pondering FAS for a while and how we can address it in Medicaid.
Yes, let me go ahead and make. Yes. Okay. Let me see if I can make the screen bigger. I'm not incredibly tech savvy, so give me just a moment to Be better at this. Let me make that small. Get rid of that. I did stop sharing, right?
It's still up, but
Oh, well, I said it says resume share, pause share, stop. How about I got it.
we're okay.
There we go. Sorry. A little embarrassing. Okay. So how can Medicaid help more, right? Was kind of the take home. So I think the hardest part is where to start, right? Chicken versus egg. Is it in diagnosis? Is it in support systems? I think one benefit or organizational thing that would be helpful at that level would have links to resources relative to what FASD is or what they are. And then being able to give that direction on a website or in local municipalities of what is, like, how do I get plugged in to ask my doctor about this, right? On the doctor side, we need to screen better. So we need to create more universal screening when we see a woman that is in preconception, right? As well as antenatal visits. So we on that side need to start implementing a universal screening. But then we say, okay, great, high five, we've screened you positive. Your coverage is Medicaid, great, because you're pregnant, that's appropriate. But what do we do with that positive screen, right? We might need one of those and then EMR is another thing that's another enigma to me. But if you could have one of those notices that fires that says, hey, this is what you need. This is how you can link them into Medicaid when they get their coverage. They had a positive screen, not to label them or again, give them a big scarlet A on their shirt, but to say, this is a person who needs resources, flag that. How can we flag that and then link them in? So I think it's a huge system-wide need, but I think that the overall acquisition of just where to go is going to be the most important, because people that want help will get it, but if they don't know where, then they just sit on their hands. And if we make it easy to access it, then they can get what they need. Funding that is supported by rehabilitation centers, especially those with heavy alcohol use, because they often will need inpatient management, but it's really inaccessible. And I'm not sure the extent of coverage that is provided in just like in pregnancy specific for substance use disorders. You guys are all much more familiar with that than I. But I know that I have local resources that I send people to and they say it was too expensive. Or I have other kids, I can't go inpatient. So what are my outpatient options? And having kind of a breakdown or a schematic of how that would work and with what's good with your coverage. Because that's the first question everybody asks.
Yeah.
Sorry if that was like verbose.
No, those are really helpful tips. I've been pondering this a lot because we've really been focused a lot on opioids. There is a lot of polysubstance use. These tend to overlap quite a bit, and FAS is just so prevalent across the population, not just Medicaid.
Yep.
I've really been pondering how we can be more effective on that. Fortunately for Texas, we have a pretty robust set of SUD benefits, including residential. The problem is getting them into providers that really know how to address pregnancy. And so that is a challenge, is providers that can work with that. And then also there are some state funded or grant funded sources for pregnant women that need to bring their children with them to treatment, but that is not a Medicaid funded.
So one thing that might be beneficial is if there was an initiative with physicians where it was like an alcohol awareness program that you could kind of do a bolo out to like a really broad net, cast a really broad net, specific region, pick a region, cast a broad net to all PCPs and OBs, right? And say, do you practice obstetrics on this survey? And then they say yes. And then it goes to the next question and they say, are you interested in offering services to support for alcohol use disorder? So, blah, blah, blah. If they say no, thanks for thanks for playing by. But if they say yes, then maybe you could follow up on those positives that you're positive screening them. And then that could kind of morph into some sort of program where you could be a certified provide, like this is our list of providers that have familiarity with this or have interest in this or capacity to do this. They do OB care and they do this. So that could be a good resource I'm a lot of big dreams kind of girl. So
Me too.
it might be a problem. But that's something that could be incredibly lucrative, not in a financial way, but like lucrative in an impact way.
Absolutely.
Yeah.
Dr. Rachel, oh, sorry. Hi, this is Jessica Wheeler Macias from Waco.
Yay.
House. Appreciate you being here today. Absolutely
No
love it. Dare I say this is even a better presentation. You're getting really good. But what I wanted to say too is that this topic has been researched in the state of Texas. I know that not many years ago, but at least 10 years ago, CADCA had done a study on polysubstance abuse with pregnant women. They were able to go through and screen these ladies, and the numbers were astronomical on how many women had tested positive. And so they released some of that data. CADCA is a very good resource if we want to kind of get a picture of what's happening in Texas.
Say that acronym again. What was it?
CADCA, CADCA.
Okay. Yeah. And I was looking more international and national. So that's really
Right.
helpful for me to kind of niche in on that.
Right. And so what the problem was, we had this wonderful bit of awareness, but there was really no follow through when it came to, okay, now that we know these numbers, like what you're discussing right now is absolutely a solution. So linking that local data with what you're talking about absolutely makes sense. So I'm grateful for you for saying those things. Thank you.
Can I give a quick timeout? We're right against the hour. If anybody would like to stay on, Dr. Rube, do you have a couple more minutes? If anybody would like to stay on and talk to you?
Sure. Happy to.
And everybody else, we'll see you next month. And Jessica, who just spoke there, is going to be our presenter next month. And Jessica, what are you going to talk about?
We're going to talk about the issues with child removal and substance use disorder. I see people clapping. Let's just say I'm going to take probably a really long nap after I talk about these really hard topics. But it's not pretty in the state of Texas, y'all, but we're not surprised by that. But we're going to talk about some potential solutions, not just in Victoria, but Texas wide.
No, I'm excited because that's a topic that we need more information about and more understanding. So I'm clapping that I'm excited to hear your presentation, not necessarily about the topic.
Okay,
right. It's a good follow through after Rachel's discussion. You have a woman that is pregnant or have, CPS involvement is an element of this. Another reason why women may not come forward. So we want to make sure that we understand these processes and that we can navigate our ladies in the right direction. This is only going to get worse, not better, with new legislation in the state of Texas. I don't have to name what legislation's passed recently, but we're going to have a lot of babies born. We need to make sure that we're prepared. Rachel. She's ready.
Anybody that needs to leave, we'll see you next month, and we'll continue this conversation. I wanted to if I could give you my deal is about adult children alcoholics. I grew up in an alcoholic household. That doesn't mean I grew up under the bridge somewhere. My people were country club people and all that stuff. They just drank a lot, and I don't know that I don't have some of this. Another family member was born developmentally delayed and had dyslexia and had to repeat a grade early on, and just struggled with learning all their life. And they say he's got dyslexia, like it's his fault. Well, somebody was drinking during pregnancy or something. And as a classroom teacher, a case that I remember vividly was a young man that I just could not get to sit and be still, and if nothing else, just be quiet so everybody else could learn. I didn't expect him to learn too much because he was just off the Richter scale. I went to an ARD for him. It was a special needs teacher, the vice principal, myself as a classroom teacher. And I got there a little early and I was reading through his record and it says 3rd grade. Jim was rolling around on the floor of the bus screaming, "You're not the boss of me," and I said, well, that's pretty typical for a 3rd grader, 4th grade, 5th grade, 6th grade, 7th. Jim was rolling around in the floor at the cafeteria saying, "You're not the boss of me." 7th, 8th grade, and he was doing this stuff his entire academic career, and it's disruptive to the other kids, but he's not learning anything. And in my ignorance at that point, I looked at him and I was trying to help him. I liked him. He was a good kid, he was just way off, I said, you're going to graduate here in a couple of years and you're going to go out in the adult world. You try this on a job, they're not going to let you, some jobs aren't going to let you live, and some, jobs you're going to get fired, you're going to have repeated trouble. And that's his pathway, and I was just trying to help him understand that, he's got to take some responsibility. And mom was there. And of course, she's, just doesn't know what to do. She's thrown up her hands. She's been told that there's nothing they can do all his life, And so it's pretty sad to see that sometime, but, connecting this to real life experiences gives us some hope that we can, like you say, it's all in the prevention.
Yeah. And it's, I thank you for sharing, by the way, because a lot of that, personal and that experience of that kid, it's hard because it's not curable and it is going to create lifelong dysfunction if it's severe in a lot of its elements. And naming it and taking the power away from the stigma of it is going to be a hard, daunting task. But I think that if it's the medical system as a whole has intentionality behind that, I think that it could help kids like that may, be walking around with just labels of he's a bad kid. He has ADHD and that's the end of it. Well, what if that's not the end of it? Or what, so I really, I just wish that it could be highlighted more or at least looked for more. And it's usually diagnosed. There's a slide that's hidden in my PowerPoint that's about how it's usually diagnosed by pediatric specialists with kids that are like this kid, like you don't get anywhere and you do all the genetic tests and you do all the developmental tests and you do everything. And they finally kind of get to that nitty gritty exposure. And then they go, oh, the exposure was there. These are the manifestations. It doesn't overlap with anything else. It's most likely this, but that doesn't happen because how many kids have the resources to go see a neurodevelopmental pediatric psychologist?
The teacher, the 2nd grade classroom teacher told us that our stepdaughter had signs and symptoms of ADHD and encouraged us to get her on medicine. We didn't want to, but we took this lady's advice and we did. As long as she was on the medication, grades were up, trouble was down, trouble at home was down. But in summer or whenever she went off the medication, it all came roaring back,
Yeah. And community involvement, feeling empowered to talk about it when it's not a stigma, right? You guys are dealers in the stigmatized. And so it is definitely something of struggle, but if you can make it more universal to be okay to talk about, then it can help people like, your daughter with ADHD. So,
well, I think without consulting my colleagues, we might have a invitation for you to our symposium.
Oh, well, thank you.
We'd be honored.
That's so sweet. So for the symposium, because you said it and I was like, I wonder what kind of symposium it is, but you said it was for lay persons and so is
medical
it
providers and
a combination. And
first
we're
responders.
we're trying to figure out how to divide out CE times,
yeah.
non-CE times.
Yeah.
And, CEs makes it complicated. So we're in those trying to parse out the sectioning. But we rented a large space because we decided go big or go home.
Get
it. Trying to get as many people that we can influence. So, because I really liked your even talking more about how to make that discussion safe.
Yeah.
Because I think our community struggles with that.
Yeah.
I think
Yeah.
everyone struggles with that. It's not, it's not fair. It's everyone struggles with that.
Yeah, what I think and I'm assuming, is this an invitation for me to attend? Or is this an invitation?
Or
for
you'll
me-
get an invitation to attend.
Um,
Save the date. That's
yes,
where we
okay.
are right now. We're just starting on the planning stages. But
Great. So I have a couple of ideas if it was to talk. But if it's to just come and learn things, I'm also down for
No,
that.
it could be to talk.
And I don't want to be like,
that would
invite
be-
me to talk, but I also I like the prospect. So yeah. I
Um,
also have another name for you.
okay.
Okay.
One of my colleagues' names is Zach Sartor, Dr. Sartor, Sartor.
Okay.
And our emails are the same formatting, like the name at Waco Family Medicine.
Mhm.
But he started our MAT clinic here. So he runs our Suboxone clinic.
Ah.
And he does obstetric care as well. And he does opioid use disorder in pregnancy. And he is a brilliant speaker. He is really knowledgeable. He actually has also helped as an editor for what's called the Waco Guide.
Mhm.
I don't know if you guys have heard of the Waco Guide, but it's a psychiatric resource for primary care providers on how to manage common medical and psychological or psychiatric conditions when they have low resources. And it's a completely free resource online. And one of the pages and the algorithms that he developed in conjunction with the Harvard School of Psychiatry and Harvard Psychiatry Department is alcohol use disorder.
Mm.
So he's an expert. So I would say he is a huge resource.
I
Could
asked
you
you.
make an email invitation? I sent my email, like if you can do a little email invite,
Mhm.
Sure.
because we really want to have a specific section about pregnancy
Mhm.
and substance use in pregnancy. And
Yeah.
I could see like a combo panel, something, or if you have some fun interactive ideas.
Yeah.
Yeah, I could see that
And,
being really a kind of a very cool thing, and providing that would be a CE provider type of.
Oh yeah, I think that would be great. And like I said, he is excited and passionate about the topic. He's actually trying to get in at Johns Hopkins for a master's in public health with
Oh, yeah.
specific development of a program for resources for substance use disorder. So he's motivated. He's real motivated.
Okay.
And I understand too, Rachel, I understand that he also streamlined a lot of his processes here recently within the last 6 months. So if someone does walk in with substance use disorder in this MAT clinic, they're seen not in 6 weeks, but in 3 days in Waco, McLennan
Wow.
County. That's incredible for a community to be able to have that kind of resource. Typically it's 6 weeks, 8 weeks, 2 months. It's very long process. And by that time we typically lose them.
Yeah.
Well, and in the community that we're working with, there's very few MAT providers.
Mhm. Yeah.
I think the last time I looked, there were 3. I think 3.
Mhm. So hold on to your hats. Are you excited to hear this? He developed it to be part of the residency curriculum. And so all of our residents go through a rotation, and the goal is to have everybody graduate with their MAT.
So we have a champion in our community that's doing that, Dr. Sid Ontai.
That's awesome.
And so that would be a really neat kind of collaboration.
Oh yeah. Yeah.
Talk
Yeah.
Awesome. Well, I appreciate you coming and sharing yourself with our ROSC.
Thank you so
And
much.
thanks
I
for
appreciate
staying
you guys
over.
having me. Oh no, I'm sure the residents are fine.
Anybody
But-
else have any last minute questions or ideas or thoughts?
No,
I'm gonna go
but
ahead and jump off and give you
Okay.
back the rest of your day. We
Thank
appreciate
you
it.
guys.
Thanks.
Thank you for
And if you
inviting
could
me.
do
I really
a-
appreciated
yeah,
it.
that email invite, that would be great, or that email introduction, and we can
Yeah. Yeah.
figure
I'll do
something
that.
out. Okay.
Thank you.
We'll be in
Appreciate
touch.
you guys.
Thank you all.
Sure.